Good afternoon, everyone. You can hear me, yes? Okay, so my name is Marwa Elamin, and I'm a clinical neurologist, and I'm the clinical lead for the Regional Specialist Memory Clinic in Galway. And my brief today is to talk to you about the value of biobanks and registries in the context of specialist memory clinics. So I'm just going to start with one slide to tell you what is a regional specialist memory clinic in the context of Ireland. And these are new entities established by the Model of Care for Dementia in Ireland, which was published in May 2023 after 4 years of work. And this model establishes basically 3 levels of care: GPs, then level 2 are so-called mass services, and these are geared towards your typical dementia, so patient who's an older individual with memory problems, and is supposed to be a local service with one service for every 150,000 of the population. And then level 3 are the regional specialist memory clinics. These are geared towards more atypical presentations, and the Dementia Model of Care suggested that there'll be 5 in the country, and there's currently 4 with plans for a 5th one. There's 2 in Dublin and 2 outside Dublin as we speak. So I'm going to talk to you first of all about what does atypical dementia means, and the value of a registry and a biobank in that context. And I also want to stress the thread throughout is, while we've been listening all morning about the importance and the value of population-based research, I just want to highlight that even within a clinic, there is a unique opportunity to carry out research that actually feeds back into care and helps us understand dementia syndromes better. So I'm going to start by just explaining what do we mean when we say atypical dementia syndrome. So if you think back, typical cognitive clinics, most patients attending are older in age, and their main symptom is memory. And it's gradually progressive. So anything that diverts from that is considered atypical. So an age of onset less than 65 is considered atypical, and that's arbitrary cutoff based on really age of retirement. And then the clinical syndrome itself can be atypical, so the main symptom may not be memory, maybe language, behavior, or the progression of the disease could be very fast in an unusual way, or there could be very unusual excessive motor symptoms like ataxia, chorea, and so on. So we consider all this as atypical. In Galway, our age of cutoff is actually 69. This is due to logistical local reasons. So we accept ages 69 or under and any atypical clinical syndrome. So we do not have a biobank yet. We're in the process of getting that. We do have, we've only established 2 years, and our registry is very young. It's only 8 months old. So I have preliminary data, which I will show you today. But even looking at our very young data, we can see that almost 60% of our patients are young, as in 65, younger than 65 when we first met them, and about 40% are older individuals. And that kind of leads to a very interesting age situation. So the mean age of the patients at our clinic is 61, which is relatively younger than most memory clinics, but the range is huge. Our youngest patient is 22, and our oldest patient is 89. So you get a wide variety of conditions. So I feel always, I feel that I have to justify my existence because people always say, young onset dementia is so rare. And this is the figure that's usually brought up, that the 8 standardized incidence per 100,000 is 11 in the under 65s and 274 per 100,000 in the over 65s. So not even 10%. Much smaller in this group. A few things I want to highlight is, number one, the denominator is not the same. Okay, so if you look in Ireland, for example, over 65 represents about 15% of the population in Ireland, while the under 65 represent 45% of the population. So your denominator is not the same. So you're comparing apples and oranges. And it's not a numbers game. So the patients who present at a younger age are a different population intrinsically, So if we look at our data, even from our very young registry, very small numbers, we can see that our younger patients, there in the blue boxes, have a higher rate of family history of dementia and have higher rate of family history of psychiatric disorders. So there is likely to be genetic differences between the two groups. But even in acquired lifestyle or lifestyle behaviors that we've been discussing all day to do with brain health, when we looked at them, our older patients were more likely to have less education, which makes sense, and more likely to have hypertension, which makes sense. The other factors, there was no difference, although there was a trend for the younger patients to have more depression rates and more history of excessive alcohol intake. Okay? Now, there's still smaller numbers that might change with time. However, this goes with the more social factors. So this is very interesting. Our younger patients are more likely to have English as not the first language. Okay, and so I would predict that the 3% in the older population who don't speak English as their first language, it's actually Irish, because we're talking about West of Ireland, while in the younger population, the almost 14% who English is not, is more likely to be, non-Irish. So we have lots of people from non-Irish ancestry, much more common, and a much higher rate of childhood and adult trauma, including war and so on, and this is self-reported trauma. So it is intrinsically a different population. So other than having a more complex background, the disease itself is different. Dementia that starts early is a different disease. It's not just, that it's the dementia that happens to start early. It's a different disease. And to illustrate this, I'm just going to give you one example. This is John. He's 62. He's a chef. And I remember him because he carried the diagnosis of functional neurological disorder. He's a chef. He could not work because he could not see. So he could not see things clearly. He had problems driving, going down the stairs. He's a chef, and I remember him telling me, I can't work anymore. When I open a jar and I put it down, I can either see the jar or the lid. I cannot see them at the same time. So he had to quit being a chef. He said it's like being in a dark room, and all you can see is little pockets, or like you have a torch and you can see one thing at a time. You can never see the whole thing. His eye tests were normal. He's been through loads of eye doctors, and he got the diagnosis of functional neurological disorder. When you test him on the ACE test, that many people don't understand why it's there in the ACE, because it's so easy and everyone gets it right, he was unable to put the letters together. His visuospatial skills were really poor, and he had, like what most of you have guessed by now, posterior cortical atrophy that was caused by Alzheimer's disease. So he has atypical form of Alzheimer's that's not recognized easily by doctors. And these atypical forms include, for example, the frontal variant that are often confused with psychiatric disorders and frontotemporal dementia, the locopenic variant where the problem is language, communication, often confused with stroke. And these atypical variants of Alzheimer's occur in about 4% of Alzheimer's disease in the older population and account for almost a third of patients in the younger population. So when Alzheimer's presents early, it wears different clothes that make it more difficult to diagnose. And this is our own data, just to highlight that not only is it presenting differently, Alzheimer's disease is less common in this population. So this is the people who are diagnosed with dementia, okay, at our clinic in the last year and a half. Only 46% the final diagnosis was Alzheimer's. In most clinics, almost 2/3, at least 80% or so will be Alzheimer's. And the reason it's smaller here is because of the smaller proportion in younger individuals where the dementia is due to Alzheimer's. You can see here a large chunk is frontotemporal dementia, which is again often misdiagnosed, a midlife crisis, depression, and so on. Other than the delayed diagnosis, the impact frontotemporal dementia has on the patient and the family is huge because of the loss of social skills. So this is a video provided by a family member for why they don't attend church anymore. This is the patient. He has frontotemporal dementia. He's very happy, very friendly, too friendly in church, which initially people are okay with, but when he becomes overly friendly, you can see how that can quickly become very uncomfortable for everybody around him and can cause problems. So they now try to avoid going to crowded places such as church. On the other side, other than this inhibition, many individuals develop apathy. So this is over here a patient who had to be admitted because of just not looking after herself, not paying the bills, not eating, not drinking, so sitting in the dark, and the GP thought it was just depression, you know. But she came in eventually with weight loss and dehydration, and you can see here from this small evaluation how there is very little internally generated actions of any sort.
Could you count to 20 for me?
I can count to 20, 20, 20, 20, 20, 20, 20, 20, 20, 20, 20, 20, 20, 20, 20.
Okay. Can we do it a different way? I'm going to have you count from 1 to 20.
1 to 20?
Could you do that?
Yes, I can do that.
Go ahead.
1, 1, 1, 1, 1, 1, 1, 1, 1, 1, 1, 1, 1, 1.
So she can mirror what you're saying, but to internally generate something new is very difficult. And some patients develop obsessive behavior that can be detrimental to their surroundings. So only last week, I saw this 62-year-old nurse who had to quit work because of basically mistakes and not caring. Her husband had a physical disability. She's his main carer. And she started caring less and less for him and spending a huge amount of time playing video games. I mean, staying up all night playing video games. Diagnosed by psychiatry as depression and OCD, and then somebody in the psychiatry clinic noticed the emotional blunting, that she was not as involved emotionally in what was going on. So she was referred for an evaluation, and her memory was excellent, superb. She was able to give me the history and tell me the amount of time that she's spending on the video games and how little and how irritable she has become and all that. When you looked at her MRI, which was reported as normal, you can see clear brain atrophy, very focused in the temporal lobe, which is classically seen in a subtype of frontotemporal dementia called semantic dementia, where the problem is loss of knowledge about the world, about what's right, about my commitments. And she was unable, although she could tell me what she ate yesterday, and her memory was superb, she was unable to recognize what this instrument was. She was unable to recognize what this dinosaur is. And when I gave her options, she said rhinoceros. She wasn't sure. And when I asked her to draw, a bird, she drew the bird and then was concentrating on those 4 legs. She knew they weren't right. And this is her depiction of an elephant. And you can see her there going with the pen back and forth here, knowing that she's missing something, but she wasn't sure. So everything went to dog and cat. And just to say, the bad handwriting is mine. So again, misdiagnosis, delayed diagnosis, huge impact on the patient and on the family. And this, just to highlight that in young onset dementia, the damage reaches well beyond the patient. So the carer burden in all young onset dementia is about twice that of late onset, especially driven by the behavioral changes, which are hugely impactful on the family. When we looked at our own data, 42% of our younger patients were still working, as opposed to 16% of our patients who are older. So it has impact on work. And those who had stopped working, in the cohort who had stopped working, 11% of the younger patients stopped because of their cognitive symptoms, as opposed to age or medical problems or whatever, as opposed to only 2.4% of the older patients. And the cost, international data suggests that the financial cost of young onset dementia is twice that of late onset. So I hope I've justified our existence as a service so far. I just want to highlight the complexity of managing these conditions, because people living with atypical dementias and young onset dementias, other than the cognitive aspect and the behavioral aspect, there's a lot of physical aspects as well. And just to highlight that in our 100 patients, only last year, 15% had a Parkinson's plus disorder, with its own set of problems, including falls and, difficulty swallowing and so on. And I think this is an interesting area where specialist clinics can contribute, okay? Because, for example, you have what's so-called rare disorders, like corticobasal syndrome and PSP. They're considered rare, okay? When I looked at that 15%, 9% of that was PSP and corticobasal, the so-called rare disorders. And these were described in the 60s. Okay, but it's specialist clinic like this that identified that people with these syndromes can present initially purely cognitively, no physical symptoms at all. Can be behavior, can be language, and that can go on for 1 to 2 years or longer before the motor symptoms emerge. So these 9% in my cohort all initially presented with behavioral symptoms, and I diagnosed them initially as frontotemporal dementia, and with time the symptoms emerged. And the physical symptoms can be very disabling. This is a patient with corticobasal. You don't need the sound here, but you can see her left arm, if you notice there, other than the jerking, other than difficulty carrying out complex movements, which we call apraxia, that arm, if you focus there in the left arm, it's doing its own thing. It's an alien limb phenomena, okay? She's just been asked to put her arms up. That's all she's trying to do. But that hand not only jerks, it's going up, it's going down, it at times even interferes with what she's doing. Can you see all those movements in the hand? These are all involuntary. This is all involuntary. So hugely distressing and basically creating a non-functional upper limb. So, and even if we don't think about Parkinson's plus disorders, let's just think of regular behavioral variant frontotemporal dementia. Your barn door behavioral variant FTD, not as a part of Parkinson's plus. A significant proportion develop motor neuron disease. And actually, that's what got me into the cognitive aspect. My PhD was actually in motor neuron disease. And there was a long debate about, is there overlap or not? Yes, there is an overlap between motor neuron disease and frontotemporal dementia. 15% of patients with motor neuron disease will develop frontotemporal dementia, and vice versa. And while that's what my focus was during the PhD, what I really learned was the value of having a biobank and a registry. So my focus was looking at cognitive change, behavioral change in Irish individuals diagnosed with motor neuron disease in the whole of Ireland. I was driving everywhere with my little car, okay? While we were doing this, okay, 2011, there was the discovery of C9orf72. Now, we knew before that there was pathological overlap between the two conditions, there was genetic overlap, but C9orf was different. It was huge. We now know it's the most common cause of genetic frontotemporal dementia, motor neuron disease, and a combination of both, okay? Because we had a deeply phenotyped population and we had a biobank, we were able to immediately ask the question, well, how are these patients different? And can we recognize them? Can we predict who carries this gene or not? So immediately we looked into the cognitive and clinical characteristics within the Irish population, because all the data was there, and you have the samples. And we were able to come up with this very simple, practical use to clinicians, that if you have a family history of motor neuron disease or frontotemporal dementia, and his behavioral impairment, then up to 70% of patients are likely to carry this gene. While if you have neither of these risk factors, the risk was zero. Extremely helpful information to guide you in your clinical practice, simply because the information was already there. And that's really a massive lesson for me. Now, we also have in the specialist clinical autogenetic disorders, so 3% were Huntington's, and I'm sure within this mixed group, there are also genetic conditions, some of which are diagnosed, and some of which I'm still struggling to diagnose. And there's also lots of reversible causes, much higher than in other clinics. So multiple sclerosis, tumors, HIV, I think 3% of our population were diagnosed with dementia relating to HIV disease, obstructive sleep apnea, B12, and so on. This is a case that's kind of seared into my brain. 64-year-old lady with rapidly progressive vascular dementia, and she came to ED 3 occasions with seizures. Her drugs were increased and she was discharged. On the third occasion, I put my hand up. I was about to do the same thing when her husband said to me, listen, I know she has a diagnosis of vascular dementia, but she was 6 months ago, she was fine. Does vascular dementia go downhill so fast? You know, and I had to take a step back and say, he has a point. Something's wrong here. This is not normal. So she was brought in, and during her admission, we saw hundreds of these arm and facial movements, hundreds. The family never mentioned them because they mentioned the big seizures. You know, these small things, they didn't think they were relevant at all. These are called facio-brachial dystonic seizures. They're pathognomonic for an autoimmune disorder called LGI1 encephalitis. Can you please see it again? Please. Okay? And this is fully treatable. This lady got had plasma exchange and immune treatment, and she went back to normal. You know, completely reversible, and I was this close to missing it. So, and now there is more and more data that many of the conditions that mimic the neurodegenerative disorders, like semantic dementia that I mentioned a few minutes ago, may be driven by autoimmune disorders, okay? If you have a biobank, you can investigate what's going on, what proportion of the people I diagnosed with semantic dementia. You have IGLON5, another one that mimics your Parkinson's plus disorders, without a biobank and collaboration, because you'll need larger numbers to really look at this. One center would not be able to do it properly. Being a regional center, we are ideally placed to look at, access, equity, social deprivation, and the effect of that, and how that will feed into when we do have therapies. How is that going to work? So, lastly but not least, I hope I've convinced you that even within a clinic, there's huge scope for providing good care, and with the help of a registry and a well-designed biobank to do research that feeds back into good care again. Thank you.